Welcome to the Friends of NPACE podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
Welcome, everyone, to the Friends of NPACE podcast. We're here in season 2. I love this job so much. I am Terri Schmitt. I'm the executive director of NPACE and a practicing family nurse practitioner, and I am incredibly excited and honored to introduce today's guest. She's an accomplished nurse and a nursing faculty. She has a specialty in palliative care, and she's an advocate for patients having death on their terms, the way they want it. So I'm excited to introduce Dr. Elena Prendergast. She's a family nurse practitioner, and I love this. Your LinkedIn page says you're a solopreneur, quality of life navigator, end-of-life doula. We're going to talk about that today. Palliative care nurse practitioner, and you're an assistant professor. You're the owner of Tree of Life Health with a focus on holistic and truly patient-centered care. Dr. Prendergast earned a doctorate degree from Frontier Nursing University, and not only does she practice and advise other groups clinically on palliative care, she's pioneering immersive reality applications to enhance empathy, which we could all use a little bit more in nursing education. And she's collaborating with interdisciplinary teams to contribute to strategic palliative care program development. Did I get all that right?
Yeah.
Welcome. I'm so excited to have you because you're like a rock star in this area.
Okay. More like a rock, right?
Nope, no. I met you the first time at AANP. Was that a year ago? A year and a half?
I think it was. Not this last one. Wasn't it the one before?
I think it was 2 years ago. And I knew when Brett Snodgrass said, you have to meet this person. And she wasn't wrong. She absolutely was not wrong. Welcome. Thank you for being here.
Thank you. I am so excited to be here. I really am, honestly. Thank you so much for the invite.
Yeah, and I think this is a specialty topic that we need to talk about more. But in season 2, one thing that we're doing in the podcast is I'm talking to everyone about how they came into healthcare or nursing. So tell us how you found your way into the nursing profession.
So I guess I can just go back, all the way back. Let's go back to 1991.
Okay.
I was a young military spouse, newly married. I was a reservist myself, and I had the first of what would be 5 miscarriages. But when I was going through that process, I had never dealt with death before. And I remember looking at my husband and saying, I can't do this death thing again. Little did I know that theme would weave through my life like this tapestry. Ultimately, unfortunately, my mother-in-law died of cancer. My mother died of cancer. My grandmother died of sepsis. My dad threw a PE and died, and then everything in between. And through all of those things, I found I experienced what's called death gone bad, if you want to call it that. What I found was failures in nursing staff and even the system to help family members through this process. And when I became a nurse, it really was at the behest of my mother, who always wanted me to become a nurse. And I really made that deathbed kind of promise that, yes, I would go back to school. And I had run away from nursing my whole life. I always tell people in 7th grade, my science teacher said, I hope you never go into science. You would starve. And I believe that, sadly. So I stayed away from any kind of sciences. But finally, my mother's death did propel me to follow that calling.
What an interesting way to get here. I'm so sorry about the loss of your mother, but it's interesting how the events in our lives really shape here and now.
Yes.
Yeah.
Yeah.
I appreciate you sharing that. So how did you end up as a nurse practitioner and then in palliative care? Were they simultaneous? Did one happen before the other?
So I became a nurse and went into critical care. And, like many idyllic brand new nurses, I really thought I was getting into this specialty where I could just save people, like our super person, right? Complex. And what I found for one reason or another is that most of my patients were not making it. Or I would have those patients that would just look at me and have this look of, please stop doing what you're doing. And so I remember asking someone, is there anything in between like them being here and hospice? And so this was way back in, 2009 or 10 when I asked that question, and no one could give me the answer, but I finally did come across someone and they said, sure, palliative care. And I was like, what is that? And I had already worked in hospice for a short time and was a little frustrated by the fact that people were coming to me too late. Mm-hmm. So I started studying up and learning about this whole palliative care thing. And I felt that was exactly it. It was that bridge between those two that was going to help our patients get the care that they needed and deserved when they had serious illness or end of life. So to answer that question, I only became a nurse practitioner to go into palliative care.
I love that so much. I love that this is your passion and that was the drive to be able to have the autonomy and empower people in part of this process of a good death. So I don't know whether to start with that question first, like what is a good death, or should we dive right into what is a death do? Like, you know this better than me. So which do you think we should define first?
Oh, it's interesting. I just got asked this question. I was with a family this weekend who I was assisting through the transitioning process. And she asked me the same thing. She said, have you ever seen a good death? What is a good death? And the first thing I would say is that I'm a firm believer of pain, quality of life, death. All of those things aren't defined by us necessarily. They're defined by the patient themselves and the family themselves. So if a good death means being surrounded by your family and reminiscing and all of those things, then it's a good death for you, right? If a good death means getting on an airplane and doing something that you wanted to do, your whole life, and you don't care if you die on the airplane, you just knew that you were going, then it's a good death for you. I think if we want to boil it down, it's the absence of suffering. Most people say they're not afraid to die, they're afraid to suffer. Most people don't want their families to suffer. So I think that's when we look at it, especially in the hospice and palliative care world, that we're not talking simply about a patient. We're talking about a family unit. And so suddenly our patient becomes the entire unit. I find it ironic that when we're coming into this world, the nurse cares for the mother and the child. And when we're leaving this world, we as nurses care for the family and the patient. So like I said, for me, I spend a lot of time trying to understand what a family would consider a good death.
I appreciate you saying that. My past work was in neonatal ICU and neonatal transport and attending deliveries. And I was on the other end of the spectrum for many years in my nursing career. And the fact that you highlight this as a transition, like we're all 100% of us have been born, right? That is a process. And 100% of us are going to die. No one gets out without either one of those transitions. Right. And we've just medicalized both of them so much, almost to our detriment. And there's not one of us that hasn't touched. So people are going to listen to this and they know they watch it sometimes, and then they listen on Spotify and Apple, and it's going to touch home because immediately someone's going to go to that experience they had when you talk about this, whether it was mom or sister or grandma or child. So I love that you talk about it in transition. We just treat it so medically sometimes. So how did the What is a death doula, and how does it fit into all of this discussion on palliative care?
Sure. So first and foremost, I will say I'm still very firmly a palliative care nurse practitioner, right? With all the credentials and everything that comes with it. But we also know that you were talking about that medical, that medicalization of things, right? And we are held within our licenses, our certifications, and all of these things. And sometimes in our work, we forget the joy and the simplicity of why we started doing what we were doing. And because I was kind of tied up with, either working for a palliative care company or a university or whatever, people were still calling me, asking me, could you help? Could you help? And by virtue of my license, right, I have parameters. But one thing that is universal that doesn't require a license is advocacy, support, and education. That I can do. I don't have to manage meds. I don't have to do all of those things, but I can educate, support, and advocate for a family member to have a certain experience. And so I did learn a couple of years ago about the role of the death doula. And so I personally became very interested in what was the training, what was the education, what do they do? Because I know what I do, but I wanted to know what a layperson was doing to support this. And so through the process of researching it, I found that the death doula is a non-medical person who comes in and supports and helps navigate a family through the end of life process. There is no national certification, so to speak, just like we have national certifications. There are different certifying bodies, but there is no one national certification that they have to take. Most of these people have come because they have this heart or an experience with death that changed them. And whether it was good or whether it was bad, it impacted them in a way that they wanted to do this work. The other thing, as a hospice nurse in the past and a palliative care professional in the present, I know that hospice is not there 24/7. And one of the reasons I was being called by all of my friends, family, colleagues, a lot of my colleagues, believe it or not, are the calls that I get. When we think about death, let's say a physician, even I think probably physicians more than nurses, because nurses do tend to see a lot of death, but the death that we see is usually a traumatic death. It is a trauma, it is a code, it is something like that. Very rarely are we trained to sit for 48, 72 hours at a time with someone and watching the changes that take place with dying. Now, if that's us who are trained, imagine the family member who is emotionally invested in this, scared, confused, sometimes not trusting the system. And you start talking about things in hospice like morphine, which some people are completely afraid of. And there's no one there to walk with them the whole time. And so to reiterate, death doulas do not replace hospice. They work alongside hospice. So there really shouldn't be a competition. They really augment the care that is being given by our hospice professionals.
So when someone gets referred to you, talk to me about how that process is. Do they say, who should we contact? Will you talk to this family? What kind of conversations then do you have? And then what's the agreement with the family for walking through this process?
So it's important to note that death doulas pretty much are fee for service, right? It's an independent person that you are hiring, just like a birth doula. Your birth doula does not, and I always take things birth and death. They are so interchangeable.
I love that.
That a lot of people can understand it. When you hire a birth doula, even if you have a midwife or an OB, that does not replace that person. That person is just in the room pretty much all the time. You're paying them to be there to help navigate, advocate on your behalf to the healthcare team. So it's the same kind of thing. Someone, either by word of mouth, or there are organizations that can do referral, would reach out to someone and say, I am needing somebody to help navigate me through this process. Most well-trained doulas will work alongside your hospice to ensure that you get the services that you need, either from Medicare or your insurance company. So they're really knowledgeable in those areas about questions to ask. When is the right time for you to reach out to hospice? Now, I think this is really important. Like you talked about the quality of life navigator, because I wear so many hats, I was trying to avoid the alphabet soup, so to speak, of titles. And so I call myself a quality of life navigator because really I think that's what it comes down to. When people come to someone like that, they're wanting a certain quality of life. And so whatever person on the team, whether it's the chaplain, the social worker, the nurse practitioner, the doula, that is the team that they are assembling to make sure that at the end of life, they have the care that they would need to have a quality death. And so it usually is cash. They're not at this time reimbursable by insurance or Medicare or anything like that. So it is a cash only business, and referrals are done pretty much like a lawyer or anyone else would do.
Okay, that makes sense. We talked a little bit about timing, and I hate to mix the confusion, but I agree that we often wait way too long to call hospice in, and then that's over, and the family doesn't have a great experience because that whole runway of communication, of services, of preparing people doesn't happen. And so do you get referrals from providers? Do you get them from hospice? Or is it really that palliative care piece, which is its own specialty, like endocrinology and everything else that consults? Where should these referrals come from? How can we help kind of connect people the right way?
So they are really two different hats, right? I wear two different roles, much like a lot of our nurse practitioners who may have an independent consulting business, which is what I consider myself, and may still work in a hospital or something like that.
Right.
So you have, what I tell people is, you have the benefit of the knowledge that person has, but they're not going to be functioning in that role. So to be very
Gotcha.
clear and distinct that this is just consulting someone on how to do something like this. Now, those referrals, like I said, for me, a lot of it is my colleagues that just know me and are like, my mom is dying, my dad, I have someone that I know. There are other people that just recently, actually yesterday, I got a call from a end-of-life doula in Atlanta who recognized the questions that the family were asking were much too medical. And so what she said was, I know someone can help consult and help you understand the questions that you're asking, and how you should ask them. And so a lot of times I think that a consultant in this role, whether it's an end-of-life doula, patient advocate, anything like that, if the work is done well, it actually helps the experience for the healthcare team as well. Because in my case, I know both sides of it. So I know the struggles that we have as healthcare providers and the barriers that people have to hospice. And then I'm able to address those in a different way without being hospice. And I think that the most important thing is to remember that this is the person hired by the family. Therefore, there's an allegiance to the family. And so the mistrust factor has now been taken away. And so that's the good thing, is that we can educate and advocate and support these families without them feeling we have an allegiance to a hospital, a hospice, or any other organization. So I think done properly, with the right person, we can actually till the ground, so to speak, to get them to hospice in a more appropriate time, so to speak.
I like that. I think that's such a good connection for everyone. It sounds to me like there's a lot of education, whether it's with the family. Is it ever with the patient, or is it really family support through the death process? Like I'm thinking a doula would be educating on this. We're just in the first stage of labor. You're going to be here for a while, and here's what we do
Right.
next. And what does that look like?
It's both. It's both.
Okay.
I think your first allegiance is going to be to the patient because it is their experience. But we also have to remember that when they die, they die. It's the family that stays there. So you kind of are juggling simultaneously two clients, but always remembering that in the end, it is what that person wants. So your first conversations should always be with that person to help identify. It's really no different than my role as a palliative care provider when I'm always sitting there. And I guess that's the difference because I've seen that side of it. I've seen the lay side of it. I understand both worlds, so to speak.
Mm-hmm.
People don't want to be spoken to. They don't want to be hearing medical jargon, and they have questions. And so the first one is to identify what is it that person wants. And a lot of times that's a lot of work. They don't even know what they want because they've spent so much time and energy thinking, I'm going to fight. I'm going to do all of these things that we hear, right? Dying is not failure. If we've tried everything that we can try, we still know at some point there will be no other options for aggressive curative therapy. There will be a point where we have to focus on what do you want? What would make this a better experience for you? And so first it's speaking to them and then educating the family, because a lot of the times we have conflicts. And so the people listening to this that are palliative care providers are going to turn around and say, that's exactly what I do. I know, that's exactly what I was thinking. Like, what do we do? But we also know there's too few of us. Statistically, we know 1 to 2%, I think that's what the statistic was, of nurse practitioners or advanced practice nurses are palliative care specialists. And we also know that we have a shortage in hospice personnel and hospice nurses. So we can't do an us against them. We have to turn around and say, how do we use our knowledge and our experience to help some people help us in this area? And I think there is so much to be said for sitting at someone's bedside and just holding their hand and saying, what you're hearing is normal. Because hospice says that, but we know it's like anything. How many times haven't we talked to a patient and say, okay, this, and this, do you have any questions? No. They leave and then they go, did they ever tell you about this? No. But they did. And so this person can reinforce the education that the hospice may have come in and already given, or the primary care provider or the oncologist. They can sit down and help reinforce those things that we've already told them.
I like that. Yeah, we need a lot of reinforcement, and especially in times of stress like that, and as family are in or out, they're going to ask a lot of the same questions. I love that it really ties that communication piece together. So now I'm going to go tangential, because I always do this when we start talking. One of the things I thought about when you were talking about how medical death is, we really have separated it from just this natural process of life. And there may not be a statistic, when we use something like palliative care or a death doula, not necessarily, hospice is its own special thing, and absolutely, but how many people then transition death from being this hospital event to being this home event? Does it make a difference?
I think the interest, I wish I had a statistic offhand to put it on. I think that's where it's so important. I know one of the things you and I talked about is like, what's the importance of the nurse practitioner in this whole thing, right? Well, the importance is that you see them before they end up at that hospital. Sometimes when they end up at that hospital, it is too late. we can't get them out of the hospital in order to fulfill their wishes of having a home death. Most people say they want to die at home. I mean, just statistics and evidence has borne that out. Most people don't die at home.
Right.
And the reason for that is that because they kind of get caught up in this system of going back and forth to hospitals and back and forth. And unfortunately, just like you talked about, when someone is under stress, when they're in crisis, they don't process, they don't hear as well. And it's not their fault. They're not trying to ignore us. They just can't quite put their minds around it. And so when someone in an emergency room, so to speak, says, we've done, and I hate these phrases, we've done all we can do. No, we don't ever do all we can do until they take their last breath. There's always something we can do. We may have done everything we can do for aggressive curative treatments,
Yes.
but they're not going to hear that. They're going to hear, you're giving up on my loved one. So very rarely are we going to have somebody decide to transition and decide, I want hospice in the hospital setting. So the best time to have these discussions is throughout their serious illness, and start really developing that relationship with your patients that basically says, hey, I'm here on your team. I am, helping navigate, your care and everything else. But also I need you to trust me that when I say we're at that point of transition, that you will trust me because you've watched me over all these years fight and advocate and give you the best, therapies that we have available. And so I think that is where nurse practitioners, I think, have an opportunity to shine in the primary care setting, is to keep them out of those final day admissions so that we do have enough time to appropriately get someone on hospice and allow them and their family, which is more important, to have the best experience that they can have at the end of life.
Well, didn't you just transition that beautifully? Because the next topic I was going to talk about was, I think we missed that window for palliative care. I know we are. I know there's not enough palliative care. I'm going to be honest, as a clinician, it's such a tough conversation to have because so many people aren't ready to hear it. And you don't want to smack someone in the face, but it's tough when patients aren't doing well. So when, as nurse practitioners in primary care, acute care, even advanced practice providers, because I would trust palliative care to be having the death doula talk. This family is going to need some support. When should I be thinking about palliative care? What are the things that should greenlight me to say, these are specialists, we should just have a discussion, right, with these people?
Well, I'm gonna preface it by saying every major organization, oncology, nephrology, cardiac, all of them say that palliative care should be brought on diagnosis of that serious life-limiting illness. Now, here's my little personal pet peeve, and I'm laughing because I'm sure my palliative care colleagues will be sitting there listening to this, raising their hands. But my problem is when you offer something, then you make it seem like it's optional. Oh. So when you're sitting at your first oncology appointment, right? Does anybody say, would you like a nurse navigator? Would you like a social worker? Would you like, someone to help you with billing? No, they introduce the team and they say, this is our team. This is a holistic team that helps you with every aspect of caring for this disease. They introduce the social worker, they introduce the oncologist, they introduce the navigator. Why are they not having palliative care sitting at the table going, this is palliative care? You take away the stigma and you take away the fear when you have introduced that person as a vital member of the team. Palliative care is the ones that deal with symptom management. They're the ones that really are at the forefront of oncology patients in particular's mind, right? Because when you get chemo and you're dealing with the sores, the burns, the skin, all of those things are things that palliative care providers can work alongside, not instead of, but alongside the oncology team to say, okay, well, we've tried this. How about this? And because of the way that palliative care bills, right? We're the ones that also could sit there and have those conversations about advanced care planning over time, as opposed to, have you done your advanced directives? Have you thought about what you want done? Should your heart stop? Anybody ask me that question right now, I'll say, do your job. My heart stops, do your job. But you'd have to put it in context for the person, to say, hey, suppose we've gone through every therapy. Suppose this is going on, and you set it up and you talk to them in such a way that now you're having them contemplate, what if we're at that point where you're frail? Your quality of life is not what you told me you want it to be. Your oncologist says, there is a 1-2% chance, that this is going to be effective. What would you like us to do then? That's a much different conversation than sign this paperwork so that we can have it on file. So I think allowing those opportunities, anytime I'm on an LVAD team. I'm the palliative care provider for the LVAD team. I meet them before the LVAD is implanted. I assess them for their understanding of the complications. I navigate them through all of the frustrations. I'm the quality of life person, because LVAD patients do have a lot of quality of life issues, up to including their intimacy, because that is a quality of life issue. And so I'm the person on the team that sits down and talks to them about that. And so I think we have to change how we introduce palliative care. And that would take away the stigma of, oh, I really don't want to talk about this.
Yeah.
Let them talk about it. That's their specialty. Just introduce it as this is a member of our team. So that's kind of my thought on the whole thing.
Oh, I like that a lot. Yeah, I practice in a very large primary care group that's very much family practice, but we definitely seek out specialists in certain areas to help us consult. So endocrinology, so I do some diabetes, cardiovascular, mental health, but palliative care is not a specialty. And you would think family practice, there are a lot of people who may have significant diagnosis who are not going to come into an oncology office. They have congestive heart failure, or they have severe COPD. They're rural. They're not going to go to the pulmonologist. They can't get in. There's a whole bunch of reasons. And there are times that we know that a patient is not doing well, quality of life is not well, and just access to that consultation and ongoing, really critical.
And I think framing it in that context, just like you said, the quality of life issues. You have 3 comorbidities that, quite frankly, we all know are going to end. Which one's going to get you first? The heart failure, the COPD, the diabetes complications. So we know ultimately where it's going to end up. It's a matter of how many years is that going to take. But I think if we establish those relationships with our patients, they trust us. And what I've found is I love my one patient who has since passed, an LVAD patient. He and I were talking, and I would get called in a lot of times when things kind of were starting to look. And we sat down and we were talking one day, and then he changed the conversation. And I followed his lead and kept talking about it. And at the end of that visit, he said to me, "Do you know why I like when they call you?" And I said, "Why?" And he said, "Because you don't have an agenda." And he truly, and which I was so thrilled, because I felt like I did my job. I do have an agenda. I have to bill. I have to do an assessment. I have to do all of those things. But the fact that he felt that there was no agenda on the palliative care person's part showed that we did our job properly. He felt like he was being heard. I was assessing as a clinician the whole time, thinking, where's his mental state? Where's his quality of life? What's going on? What am I observing? However, and the funny thing is, at the end of it, like we joke, I go, okay, I have to listen to your heart and lungs and all those other things. But he was okay with that because he felt like he had been heard. He felt like I had no agenda. He just knew I had to do what I had to do as a clinician.
Yeah.
And so I think that that's the mark of doing the job well, is that they feel we're invested only in them.
I appreciate that. All right, I'm going to ask 2 more big questions, and then I'll let you fill us in with anything else you think is important for this advanced practice provider audience that listens. My first one is, did you add the death doula hat because you felt like it was the missing piece, or something families needed that they weren't getting, or did it just kind of fit into the picture as a whole? Talk to me about why you made that decision to also provide that service.
Yeah. I'm an educator at heart, whether I'm in a classroom, whether I'm in a patient's room, my husband says, you'll educate people on BOGOs on the Publix line.
I love it.
He jokes around. So I am an educator at heart. And so what I started to see was there was also a population, and so I'm going to draw it to nursing because, of course, we're nurses, right? There's a population of nurses that retire and still want to help. And they still want to feel useful. They don't want to work. They don't want to fill out paperwork for a hospice. They don't want to do those things, but they want to do the thing that they came into this to do, which is to care for people, to use their knowledge for good and not harm. And so as an educator, I did have retirees and other people that were saying, hey, teach me to do what you're doing. Well, I can't teach you do what I'm doing because I'm a palliative care nurse practitioner who's board certified. So are you going to come and join me there? That's not what they were talking about. They were saying, teach me to talk to families and patients, teach me to sit at a bedside and anticipate the needs of a patient, teach me how to advocate. Now, I don't have to teach them because nurses are so good at those things. And so I did it to find out, like, what are these people that are not us doing? And I found out they're doing a lot of what we already do as nurses. And what I mean by that, not the technical medical stuff, but the heart work. And I think really that's what it comes down to. I haven't talked to a nurse yet who says they don't feel passionately about being an advocate, about being an educator. Most of us, I would say most of us, we put that hat on before we put on any other hat. And so for me, what drew me to it is to help educate and be able to guide some of my colleagues who didn't want to give up being a nurse because they chose not to work in a job where they were getting paid. The family members who went through something very traumatic and said, I wish I could be a nurse, but I'm 60 years old. I'm not going back to school, but I wish I could take care of people this way. And so I think this role helps them to be able to use their heart, their talents, their empathy. We talked about empathy in the beginning, in a way that is going to help people when they are truly at their most vulnerable. And so for me, the hat came on. I mean, I'd always been doing it, honestly. Before I was a nurse, I was doing this. And that's the interesting thing. When I was becoming a nurse, I thought that's the kind of work I would be doing. Then I realized there's paperwork, there's charting, there's medications, there's all kind of things that are very technical and specific that weren't 100% the heart work that I wanted to do. Even when I was a hospice nurse, I had to chart, I had to assess, I had to document. I had several patients amongst 13 counties in rural areas that I had to go visit. So no, I didn't have all that time to sit, 2-3 hours at a time and comfort them and help navigate them and help just hold their hand. So I think it was kind of one of those things that was before nursing, kind of got threaded through. And then ultimately as an educator, I thought this is something that I can help some of my colleagues that still want to do something like this.
Such a beautiful destiny of all of these things that tie right together through your entire career. I appreciate you sharing that. My next question is, tell us a little bit about Tree of Life, about what you do and where people can find you, because I think you're a fantastic resource.
So I created this LLC several years ago. Hadn't really done anything with it, I'll be honest with you. I think, I say that my motto is that I'm enhancing lives through education, support, and advocacy. And that's truly what I consider myself as a quality of life navigator, whether it is educating my colleagues in professional forums, such as having discussions, podcasts, speaking, presentations, all of those things to bring awareness to end of life issues, or whether it's teaching my students in a classroom, and then it gave me the opportunity to serve as a consultant. I was speaking to somebody notable who teaches nurse practitioners to open their own practice. And she had asked me about my practice. And I was so glad I spoke to her, because I'd always struggled. I was like, I don't have a practice. Because I didn't necessarily, for myself, it was almost like this imposter syndrome of nurse practitioners, right? Because I was like, I'm not in primary care. I'm FNP, but I'm not doing this. And I really felt like, okay, I guess I don't really have a practice. But then I realized there are a lot of people that need to consult on, how do I have this conversation with my patient? How do I, what kind of resources are out there that I can point them to? And so this allows me an avenue to be able to reach a larger audience than just working for one organization. And so locally, a lot of people ask me, you want to come work for our hospice? And I choose not to, because I want both the clients to feel that I'm not vested in anything in particular, but I also want those hospices that need the education. And I do. I feel that their nurses need education. And so this allows me to say, hey, I'm a free agent. I'm just a consultant, and I can come in, do education. I can help you with some of the systems that you have, look at them and say, okay, I might consider this or this. And honestly, like I said, I just came off of a 48-hour stretch. We were talking about it, where I was, the term that people use is vigil. And that's kind of when you're sitting at people's bedsides. And so I'm going to go back a second and mention that death doulas or end of life doulas, or whatever they choose to call themselves, they choose what parts they want to do. Some people do not want to do vigil work. They do. It's like a midwife who chooses to see the patients in an office but not do the deliveries. So they choose to say, nah, that's not my thing. I don't want to be there. Or they choose to say, hey, I am great with priming the ground for advanced care planning. Or so they can choose. I don't put myself out there as a vigil person, so to speak, but for close friends and colleagues, I will. And so I just came off of 48-hour vigil work for a very close friend of mine. And one of the things that I was struck with is that I was watching the systems of the hospice and the ALF that they were in. And so I was wearing two hats, looking at it as, how's this family member feeling? And then as a healthcare provider, like, where are the missteps in the system? And so I think because I don't wear just one hat, it does allow me as a consultant to come in and say, if you would like a suggestion, this was my observation. This was the family's experience. A lot of people, because they have to, right? They send out these surveys. I don't know about you, but when my family member dies, I'm not inclined to sit there and tell you, I'm probably going to tell you all the bad things that happened, but I'm not inclined to tell you the things that I observed that went well. And so I think having someone there that is not invested as like the family is emotionally really helps you to have the eyes also to say, hey, I observed this. Like in my case, it should never take 12 hours for 2 medication changes to take place. And so that's being unbiased, but that's also having the knowledge that this family member was in distress. And I know as a provider that should not have taken that long. And so we can see things like that. So I think in that sense, it's really helpful.
Yeah, definitely good insight into all parts of the system. Gosh, so much to talk about. I hope you and I can talk again in the future because there's so many ways I want to take this, but I think what I appreciate the most about this conversation is just your passion for it is just so palpable. Like it's a part of who you are. It's how you're
It
living
is.
your truth. And that has so much impact just beyond that the single patient. So thank you for being here and
Thank
doing the work you
you.
do
Thank you so much.
and
I really
teaching
appreciate it.
because we need all the great teachers.
Yeah, it's just you're right. There is so much we could talk about. I mean, communicating, the dying process itself. My friend who is a physician, um, she recently went through something, and one of the things that struck me is that she had said, I didn't know about all of
Mm.
this. And, by all of this, we're talking about the senses of dying, the smells, the sounds, the feel, just that you can't translate that in a textbook. And that is something that is it's important for us to understand it for our own personal. All of us will have a family member die, like you said, or helping our children when our time comes, right, is to understand that it's not like in the movies. Unfortunately, I wish it was that great. It was just like, here we go, it's done. It's a process. Unless you have a premature delivery that happens quickly and unexpectedly, that's a process.
Right.
And once again, like I said, I always correlate birth and death. And I really could point to every single part of the birthing process and parallel it with the death process,
You
honestly.
you definitely could. And I'm not sure either one of them are something that we as clinicians have much lived experience with. It's still separate from us. And that's
Right.
partially why we separate it from the family and make it so clinical, is I think maybe our own discomfort and lack of lived
Yeah.
experience with that. And it really does take living it. And we're all, look, yes, we have to plan for our own deaths, family members' deaths, and this is probably a call out, but we're all going to lose patients. And there's
Yeah.
no way around that. And so we have to be as prepared as we can be. And maybe this is the first step in just calling providers to understand that process more than just
Yeah.
statistics and
Like
recommendations,
in, yeah, like
guidelines.
anything, talking about something takes the fear of it away. Educating somebody about what to expect takes the fear away. And I think it's the same thing with us as colleagues, being given the tools that are out there to help them have these conversations, being able to recognize our own discomfort and how to address those things, I think really helps. And sometimes it's just like anything, we say, I don't know. I, you know, and that's okay. And that's
Yep.
okay. But I do know it's like the Joint Commission, right? I don't know, but I do know where to find it.
I love that answer. Yep. And I love your emphasis that dying is not failure and it's a transition. You started us talking about transitions, and it's an exciting transition that we should know a little bit more about. So thank you, Dr. Prendergast, for being here with us today and just imparting
Thank
your
you so
knowledge.
much for having me. It is an honor. And I'm just very excited. Thank you.
Eh, Can people find you? Do you prefer your LinkedIn page if people want to reach out to you?
Yeah, that would probably be the best way to get to me because I have a link to my website, which I'm currently trying to change. But for now, I do have it in there and how to get in touch with me. But yes, my LinkedIn page would be the best way.
Perfect. We'll get them there. To all of our Friends of NPACE podcasters who follow and listen, we're on Apple, we're on Spotify, we're on YouTube. You can find us all of those places. And PACE is an ANCC accredited provider for continuing education, and several of our events also have AAPA Category 1 CME credit this next year. We're really trying to build some bridges with our fellow APPs. So we offer in-person, online, on demand, all of those things, but we are very proud of this podcast because we just get to talk to really fantastic people like Dr. Prendergast. Thank you so much again for being with
You.
us, and we'll see you guys on the next episode.